You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode will cover ARVC, arrhythmogenic right ventricular cardiomyopathy, and CPVT, catecholaminergic polymorphic VT. Let's start with ARVC. ARVC, which is due to an autosomal dominant mutation in a desmosomal protein called plakophilin, has progressive ventricular myocyte loss with replacement by fatty or fibrous tissue. This results in progressive ventricular dysfunction that may involve both ventricles, but especially the right ventricle. It will cause ventricular arrhythmia, syncope, or sudden cardiac death in the second and third decades of life, often during physical activity. EKG of ARVC will show T-wave inversions in the anterior precordial leads, V1 to V3, left bundle branch block, and sometimes additionally an incomplete right bundle branch block as well, and high frequency, low amplitude deflection at the end of the QRS complex in many leads called epsilon waves. When you see monomorphic VT with a left bundle branch block morphology and an inferior axis, meaning a positive R in 2, 3, and AVF, it can be either from idiopathic RVOT-VT or from ARVC. Do not confuse the epsilon waves of ARVC with the Osborn waves of hypothermia. The Osborn waves are typically higher in amplitude than the epsilon waves. Echo of ARVC will show RV dilatation and RV dysfunction. Cardiac MRI of ARVC will show fibrofatty infiltration. The 2017 V guidelines say, in patients with suspected arrhythmogenic right ventricular cardiomyopathy and ventricular arrhythmia or electrocardiographic abnormalities, cardiac MRI is useful for establishing a diagnosis and for risk stratification, Class 1. Proturinol challenge is used to provoke ventricular arrhythmias in ARVC or as an adjunct to tilt table testing for syncope. Although VT is the most common manifestation of ARVC, supraventricular tachycardias such as atrial tachycardia and atrial fibrillation are present in up to 25% of patients with ARVC. Let's move on to medical management, ablation, ICD, and lifestyle measures for ARVC, starting with medical management. Beta blocker therapy is recommended in patients with ARVC and any of the following: recurrent VT, appropriate ICD therapies, inappropriate ICD interventions resulting from sinus tachycardia, SVT, or AFib or aflutter with rapid ventricular rate. Although diltiazem is used in the general population for rate control of atrial fibrillation, diltiazem is not preferred in ARVC patients. Instead, you should use a beta blocker. According to the 2017 AHA-ACC guidelines on ventricular arrhythmia and prevention of sudden cardiac death, in patients with arrhythmogenic right ventricular cardiomyopathy and ventricular arrhythmia, a beta blocker is recommended. That's a Class 1 recommendation. In patients with clinical evidence of arrhythmogenic right ventricular cardiomyopathy but not a ventricular arrhythmia, a beta blocker can be useful, Class 2A. So basically all ARVC gets a beta blocker. It's just that the strength of the recommendation is higher if there's evidence of a ventricular arrhythmia. How about ablation? Catheter ablation can be pursued for ARVC patients who have recurrent VT refractory to beta blockers. In contrast, in things like RV outflow tract VT, catheter ablation is an acceptable first-line therapy. The 2017 AHA-ACC HRS guidelines on ventricular arrhythmia and prevention of sudden cardiac death say, in patients with arrhythmogenic right ventricular cardiomyopathy and recurrent symptomatic sustained ventricular tachycardia in whom a beta blocker is ineffective or not tolerated, catheter ablation with availability of a combined endocardial epicardial approach can be beneficial. That's a Class 2A recommendation. In asymptomatic patients with clinical evidence of arrhythmogenic right ventricular cardiomyopathy, an electrophysiological study may be considered for risk stratification, Class 2B. What about implantable cardiac defibrillators? The 2017 VT guidelines say, in patients with arrhythmogenic right ventricular cardiomyopathy and an additional marker of increased risk of sudden cardiac death, an ICD is recommended if meaningful survival greater than 1 year is expected, Class 1 recommendation. what do they mean by a additional marker of increased risk of sudden cardiac death in ARVC? They mean having either resuscitated sudden cardiac arrest, sustained VT, or significant ventricular dysfunction with RV ejection fraction or LV ejection fraction 35% or lower. That's what they mean by additional marker of increased risk of sudden cardiac death in ARVC. They also say, in patients with arrhythmogenic right ventricular cardiomyopathy and syncope, presumed due to ventricular arrhythmia, an ICD can be useful if meaningful survival greater than 1 year is expected, class 2A. So basically, you need one of the following to get an ICD. Syncope gives you a class 2A ICD. Resuscitated sudden cardiac arrest, sustained VT, or ejection fraction less than 35% in either left ventricle or right ventricle, those gives you class 1 indication for ICD. How about lifestyle and exercise? ARVC patients should be advised to avoid competitive sports and endurance training due to their increased risk of ventricular arrhythmias and sudden cardiac death. Physical activity actually accelerates structural progression of arrhythmogenic cardiomyopathy. But it is okay for ARVC patients to drink alcohol, unlike Brugada patients, and to drink caffeine. The 2017 VT guidelines say, in patients with a clinical diagnosis of arrhythmogenic right ventricular cardiomyopathy, avoiding intensive exercises is recommended. That's a class 1 recommendation. ARVC patients are allowed to engage in low dynamic component, low static component sports, which are golf, bowling, cricket, curling, riflery, and yoga. Examples of high dynamic component, low static component sports are badminton, cross-country skiing, field hockey, race walking, racquetball or squash, long-distance running, and soccer. Examples of low dynamic component, high static component sports are bobsledding or luge, throwing, martial arts, rock climbing, sailing, water skiing, weightlifting, and windsurfing. Examples of high dynamic component, high static component sports are boxing, canoeing, kayaking, cycling, decathlon, rowing, speed skating, and triathlon. That's all I have for you for ARVC. Now let's talk about CPVT. Catecholaminergic polymorphic ventricular tachycardia is VT that is triggered by exercise or emotional stress due to leaky ryanodine RYR2 calcium release channels, which account for 50% of the cases of CPVT. The treatment is aimed at making the ryanodine receptors tighter. The second most common cause of CPVT are mutations in calsequestrin. The hallmark of CPVT is exercise-induced bidirectional VT in a young man who had a near drowning, where we think it's long QT syndrome type 1, but the ECG shows no evidence of long QT. 30% of CPVT patients have a family history of sudden cardiac death or stress-induced syncope. CPVT may manifest as exercise-induced PVCs in bigeminy that are bidirectional and not actually show up as full-blown VT on exercise stress tests. Bidirectional VT can be caused by two conditions, CPVT or digoxin toxicity. Digoxin toxicity can also have bidirectional VT, but that occurs at rest with exercise. Management. Now, we no longer give ICD to CPVT eagerly, except after aborted cardiac arrest. CPVT is best suited for medical management or sympathetic denervation because the ICD will repeatedly shock CPVT at a high rate. Nadolol plus or minus flecainide is the treatment in CPVT. Nadolol blunts the impact of catecholamine surges. Left cardiac sympathetic denervation is another treatment. What do the guidelines say about CPVT? According to the 2017 AHA-ACC-HRS guideline for the management of ventricular arrhythmias and the prevention of sudden cardiac death, in patients with catecholaminergic polymorphic VT, a beta blocker is recommended. That's a class 1 recommendation. In patients with catecholaminergic polymorphic ventricular tachycardia and recurrent sustained VT or syncope, while receiving adequate or maximally tolerated beta blocker, treatment intensification with either combination medical therapy, such as beta blocker and flecainide, left cardiac sympathetic denervation, and/or an ICD is recommended, class 1. How about athletes? Can athletes with CPVT participate in competitive sports? According to the 2015 AHA-ACC Scientific Statement on Eligibility and Disqualification Recommendations for Competitive Athletes with Cardiovascular Abnormalities, it is recommended that symptomatic athletes with any suspected or diagnosed cardiac channelopathy be restricted from all competitive sports until a comprehensive evaluation has been completed, the athlete and his or her family are well informed, a treatment program has been implemented, and the athlete has been asymptomatic on therapy for 3 months. Class 1. For an athlete with previously symptomatic CPVT or an asymptomatic CPVT athlete with exercise-induced premature ventricular contractions in bigeminy, couplets, or non-sustained ventricular tachycardia, participation in competitive sports is not recommended except for the Class 1A sports that I read out to you earlier, which are the low dynamic components, low static component sports. Class 3 recommendation. That's all I have for you for CPVT and ARVC.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.